Hi, my name is Jade Ivey, and this presentation will be on hyperlipidemia. On this slide, we will talk about the background of hyperlipidemia. Serum fat and cholesterol circulate as lipoproteins, and they are formed through two different pathways: the exogenous pathway, which is the dietary intake, and endogenous, which is the liver synthesis. Cholesterol, there are three different types. There is low-density lipoprotein, or LDL cholesterol. This is the bad cholesterol. There's high-density lipoprotein, or HDL. This is the good cholesterol, as it helps remove the LDL. There's also very low-density lipoprotein, or VLDL. These contain a high amount of triglycerides, and high levels of triglycerides are associated with an increased risk of cardiovascular disease. And then atherogenesis is an important process to talk about when talking about hyperlipidemia. This is a two-step process. In the first step, when LDL levels exceed the threshold of 100 milligrams per deciliter, they can cross the arterial wall, become embedded in the arterial lumen, and form a plaque. The second step of this is when scar tissue forms over that plaque and creates a fibrous plaque. These are what is responsible for most acute vascular events. VLD levels also contribute to this process as they are rich in triglycerides. Physical assessment findings and the clinical presentation for hyperlipidemia, this disease does not present with symptoms. It's asymptomatic itself until it leads to cardiovascular disease. Some associated findings could be obesity and an elevated blood pressure, and a lot of risk factors you will see, such as diabetes and smoking. For diagnostic findings, they are an LDL level over 100, triglycerides over 150, and a total serum cholesterol of 200. Next, we will talk about the pharmacologic treatment of hyperlipidemia. All of these medications are used to lower lipid levels in the blood, whether it be cholesterol, triglycerides, both, or to increase HDL levels. The choice of medication is specific to the patient's lipid profile, the presence of other risk factors, and the individual's response to the therapy if they have any side effects. The first drug we will go over are statins. The mechanism of action for statins is that it inhibits an enzyme involved in cholesterol synthesis in the liver, so it works on the endogenous pathway. It primarily lowers LDL and can have a modest effect on triglycerides and raising HDL levels. An example of this drug is Lipitor. Side effects include myopathy, hepatotoxicity, and diabetes. Monitoring needed for this would be to assess liver function and lipid levels initially, and then every 3 to 4 months. Patient safety considerations: it is safe for men, women, high or low LDL levels. Implications for use: the only thing to note here is there is a high potential for drug-drug interactions with statin therapy. Next up, we will talk about bile acid sequestrants. The mechanism of action for these is that they bind to bile acids in the intestine, so they cannot be reabsorbed. The liver can then make more bile acids to lower the LDL levels. Side effect of bile acid sequestrants are gastrointestinal issues such as constipation, bloating, and gas. These medications are good for pregnant patients or patients with moderately elevated LDL levels and a low cardiovascular disease risk profile, or that they have triglyceride levels below 300. The third medication I'd like to discuss is ezetimibe. Ezetimibe inhibits the absorption of cholesterol in the small intestine. It can lower LDL levels by 13 to 20%. It's often combined with statins for a synergistic effect. Side effects include hepatic impairment and headache. The next medication we will discuss is PCSK9 inhibitors. These inhibit the protein PCSK9, which leads to an increased removal of LDL cholesterol. This is an injected medication, so side effects include injection site reaction as well as flu-like symptoms. These medications are good for a patient who has not been able to tolerate the side effects of statins. It also doesn't cause increased glucose issues like with statins, so it could be considered in someone with diabetes. It also lowers LDL more than statins, and it is not first line. It's for extremely high risk, high cardiovascular risk patients that have high lipid levels due to genetic issues. Next, we will talk about fibrates. They activate a receptor that plays a role in lipid metabolism. So they primarily lower triglycerides, and they can also raise HDL levels. There are gastrointestinal side effects, increased risk of gallstones and muscle pain. It's not the first line because it has a modest effect on lowering LDL cholesterol. And there is niacin or vitamin B3. It inhibits VLDL in the liver. It lowers the LDL cholesterol and the triglycerides while we're using HDL. Side effects, the most prominent side effect is flushing. And then omega-3 fatty acids, they work by suppressing lipogenic gene expression. They reduce triglycerides and may have a modest effect on raising HDL. There are gastrointestinal issues with this one as well, and they do have a fishy aftertaste. They are also a good adjunct to statins. And the final medication we'll talk about is bempedoic acid. This inhibits an enzyme that's involved in cholesterol synthesis. It works by reducing LDL levels. It's used as an adjunct to diet and either maximally tolerated statin therapy or ezetimibe. Side effects include muscle pain, elevated liver enzymes, and increased uric acid levels. Next, we will discuss some options for non-pharmacologic treatment, starting with diet. The DASH diet, which is low in sodium, and the Mediterranean diet, which focuses on healthy fats like olive oil and nuts, are recommended. Just the avoidance of heavily saturated fats and an increased fiber intake. Exercise is recommended 150 minutes of moderate activity a week, so this could be cycling, swimming, brisk walking, and just increasing your activity throughout the day, like taking the stairs, going on more walks, and participating in gardening. Muscle strength training should also be engaged in 2 days a week. The patient should maintain a healthy weight and stop smoking. We can help them do this with medications or recommending them to counseling. Alcohol intake should also be limited to 1 to 2 drinks a day, depending on their gender. These interventions will be discussed further when we get to the supporting evidence section of this presentation. Next, we will discuss some patient education and monitoring of the therapeutic response. So we should educate our patient about the importance of monitoring and to track this progress. It gives them a visual of how they are doing with their treatment since there are no symptoms associated with it. We should also educate them about the scheduled blood test for cholesterol and triglyceride overall lipid levels every 3 to 6 months. To assist in ensuring follow-ups, we should make sure our office is doing all that they can with phone alerts like text messaging and phone calls to make sure that our patients are able to attend these appointments. We should also let them know what is going to be done at the follow-up appointments, like reviewing test results, suggesting medications, checking for any side effects that they have. And we should also have open communication with our patients to ensure that they are following up. Cultural considerations to include in patient education would be inquiring about the patient's specific dietary, like cultural foods, and suggesting recommendations specific to them and how they are preparing these foods. We should also use culturally relevant examples and scenarios and provide written materials that are written in their preferred language. To ensure adherence, we should simplify their drug regimens as much as possible, make sure that they are aware of the side effects and to report these side effects so we can come up with a better pharmacological plan for them. And then tools and reminders could be helpful, like pill organizers, alarms, or apps to help them stay on track with taking their medications. To address psychosocial and socioeconomic factors that may impact our patient's plan of care would be to assess their access to resources, provide referrals to community programs that can help them, ensuring that they have social support, encouraging them to be involved in their communities and support networks. Mental health issues should also be addressed, such as depression and anxiety, which can impact how well their adherence to lifestyle changes and the medication regimens is. So we can provide referrals to mental health professionals if needed. We should also empower our patients. Every little step that they make adds up. On this slide, we will discuss more of the supporting evidence. This first study is Reduce It by Bott et al., published in 2019. This was the first prospective placebo-controlled randomized trial of icosapent ethyl, which included a large and diverse population across multiple centers. The results noted reductions in cardiovascular death, myocardial infarction, stroke, and hospitalization when they took the icosapent ethyl. The rigorous design of this multi-center randomized double-blind placebo-controlled trial provides robust evidence for the efficacy of this drug with a 95% confidence interval that confirms the reliability of these outcomes. The second study we have is called PREDIMED. This studied the Mediterranean diet and the impact it has on cardiovascular outcomes. So they found that 30 and 28% reduction from using either extra virgin olive oil or nuts reduced the likelihood of myocardial infarction, stroke, cardiovascular mortality. The second article we have is called PREDIMED. This was conducted in 2014. It was the largest prospective randomized controlled experiment examining the effects of a Mediterranean-style diet on cardiovascular outcomes. It was a parallel group, multi-center randomized trial. It demonstrated significant reductions in cardiovascular events when participants followed a Mediterranean diet that was supplemented with extra virgin olive oil or nuts. The third article we have studied the effects of aerobic exercise on lipids and lipoprotein. It was a systematic review. The third article was a systematic review of the effects of aerobic exercise on lipids and lipoproteins. Their findings supported that exercise can significantly increase HDL levels while reducing LDL levels and triglycerides. Their review supported at least 150 minutes of moderate intensity aerobic activity a week to reduce adverse cardiovascular outcomes. The next article we will discuss is a systematic review that examined the effects of patient-centered education in managing dyslipidemia. It included 20 randomized trials, used PRISMA guidelines, used a PICO framework, used the Critical Appraisal Skills Program for randomized controlled trials to support robust and reliable findings. They only used randomized controlled trials. They found that rapid reward systems, collaborative care, systematic follow-up, social support, and e-health interventions were helpful in ensuring patient-centered education and better outcomes. The final article was also a systematic review that examined the relationship between hyperlipidemia, cardiovascular disease, and stroke. This study also followed PRISMA guidelines and appraised the quality of the evidence using the Critical Appraisal Skills Program tool, and they found a positive association between elevated LDL cholesterol levels and the incidence of coronary heart disease. And this is my first page of references, followed by the second page. Thank you so much for taking the time to listen to my presentation.